This week on the BackTable podcast.
I get what I can get. I mean, sometimes my angle coming in is not ideal to like get a little bit of bone. But right. I would say I aim for a little bit of bone, a little bit of disc every time.
Okay, that's fair. And I don't know if, I can't say for 100% this is right. I always was under the impression that the infection started in the disc. And so my first go, if someone comes to me, I'm going to biopsy disc. And if I'm getting material out from disc, then I call it good.
Hello, everyone, and welcome to the BackTable MSK podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on BackTable.com. First, a brief message from our sponsor. Stryker's interventional spine business offers the control you need, the flexibility you want, and the quality your patients deserve. Stryker is your partner in making healthcare better. From technology to training, from reimbursement tools to patient education, Stryker is there to support you every step of the way. Innovation is the driving force at Stryker. Their extensive product portfolio for vertebral augmentation and radiofrequency ablation procedures ensures that you have the tools needed to provide top-notch care. But their commitment to advancement doesn't stop there. With recent additions like the OptiBlate bone tumor ablation system and FDA 510(k) clearance for the SpineJack system for compression fractures that result from malignant lesions, myeloma, or osteolytic metastasis, you'll be eager to explore all the solutions Stryker has to offer. Learn more at www.strykerivs.com. Now, back to the show.
Hey, everybody. Welcome to the BackTable podcast. We are, again, Chris and I doing another sort of basic topic or routine topic. Not always that basic. Sometimes these can be kind of tricky. You may have caught our prior bone marrow biopsy episode that came out a couple months ago. We'll reference that in the show notes. And at that time, if you caught the end of that, we talked about extending the conversation and talking more about actual bone lesion biopsies, which come up pretty often as well. Mostly, common things being common in the setting of metastatic disease. And we'll get into indications and, why those pop up, where they come from, referring docs and so forth. The other thing we're going to talk about a little bit, because it's along the same lines, is disc biopsies, intervertebral disc biopsies, usually in the lumbar thoracic region, patients that have typically discitis or some sort of inflammatory process. And so we'll talk a little bit about that. My guest and co-host and good friend, Chris Beck, is here to join us. Welcome, Chris.
Aaron, thank you for having me on the podcast. I appreciate it. Yeah. I don't know if we officially call these things, but I feel like this is like BackTable Back to Basics or something like BackTable Basics, something like that.
Yeah, and this one will be on the MSK show where, this will be a dedicated MSK episode. I think this one will be good for our MSK-focused colleagues. And I did want to jump into, first off, basically, how are these patients presenting in your practice? Chris, we'll start off with like the bone lesions, and then let's segue into the disc biopsies.
Sure. Bone lesions, commonly, oncology referral, oncology, surgical oncology, rad-onc, someone in the oncology space usually sends those patients to us. But every now and then you have someone who presents with, like from a primary care doc, where they do some kind of CT scan, find a bone lesion that kind of warrants a biopsy. So less common, but not so infrequent that we're not used to dealing with it. But by and large, majority of consults flow through oncology practice.
And for those bone lesions, what kind of imaging do they typically have already?
So if it's an oncology patient, they're usually, it's either a CAT scan, chest, abdomen, pelvis, where you're doing like metastatic workup and like that they're under surveillance for that, or sometimes they're on PET surveillance. But also, we can find it on MRIs or potentially like a spinal MRI that picks up a bone lesion, not uncommon also. But basically, all walks of cross-sectional imaging will kind of flow through in terms of like bone lesions.
Yeah, totally. You're right. It's usually a CT. And sometimes when it's like in a tricky spot that you're like, that's going to be tough to get to, you'll ask them, hey, are they, can they get a PET just so we can confirm that this is, it's a sclerotic lesion? Can we just confirm it's not like a bone, island or something? And they're like, well, we can't get the PET unless we have the diagnosis.
Issue,
right?
Sure.
Yeah.
Not uncommon.
And so that's kind of that double-edged sword where it's kind of tricky sometimes. You're just like, okay, fine, we'll just go ahead and give it a shot and see what we can get. And those can be like rib lesions that are on the inside of the rib, or real tricky places where you don't want to cause more harm than good, right?
Sure. I'll say that, so if it's that scenario in that like we kind of found like a bone lesion with not like a super high pretest probability for being malignancy, it's not infrequent to get some additional imaging. And in fact, a lot of times, like if you find a bone lesion like on a spine or something, I really do like to complete like a staging workup, like if for some reason they haven't had like a CT, chest, abdomen, and pelvis, because even when we find bone lesions, sometimes the first thing that I'm thinking is, can we find a lesion that's in another spot? I mean, not that I can't do bone lesion biopsies, but certainly if I can find something that's in liver or a soft tissue met or some low-hanging spot in the lung, then I'm probably going to go for like a solid organ biopsy over a bone biopsy. And so I will get like some complete imaging, like just to round out, like finding something that's a little bit easier with like a better risk profile for a biopsy.
Totally. I mean, sometimes...
Yeah,
some
not
cases,
uncommon at all.
Yeah, it could even be like a big pleural fusion that looks
exactly
nasty, like metastatic. And you're like, well, let's just take this fluid off and make, if there's cancer cells, and chances are this whole process is metastatic disease,
Yeah, but that never really...
tricky. Yeah.
Well, and that also never gets you all the way there. Like, it's like they can find malignant cells in the infusion. They're like, all right, it's a malignant infusion, but there's never enough to send off for like everything that they need. So, but yeah, like looking for another spot is like, so whenever I see a bone lesion, I'm always thinking, is there an easier spot to biopsy? And also, like, I've run into the PET situation where it'd be great to get a PET to know if it lights up or not. That's not always available. And so the next best thing for me is CT chest, abdomen, pelvis with contrast. Like, especially if I'm just doing like, where might another metastatic lesion be? Maybe at a lymph node or the lung or a liver. CT chest, abdomen, pelvis gets me 95% of the way there. Okay.
So let's just run through the bone lesions first, and then we'll start over again with the disc stuff. So, we talked about imaging already, basically, what they might have already and what you would need if it's something like, they picked it up on an X-ray. You're like, okay, let's get some more imaging here before we, put them through a procedure. That might come from a primary care doc, right? An oncologist typically will already have like a CT or MRI or PET scan, one or the above.
Agreed.
Yeah.
I'm not going to do anything based off an X-ray.
Right. I would agree. So starting with we could do hypotheticals throughout the body. I would say most commonly it's either a pelvic bone lesion or a spine lesion. Thinking back, sometimes it's in the chest. It could be a rib, could be a sternal biopsy, but let's say it's an iliac bone biopsy. I feel like those are come up very commonly. Talk us through, your conversation with the patient, and then, how you're positioning them, what modality you're using to target that lesion.
Sure. I don't want to back us up even further just to cop out on the question, but I will say and it's not like I don't like doing bone biopsies, but they can be less high yield than other places. And so the other thing I would say, so I've looked at all the other spots. There's no solid organs to go for. If I am going to biopsy a bone lesion, I do kind of look for a couple of things. And one of the things I look for is if it's totally intracortical, that's less preferred. Obviously if you have a bone lesion where you can see a big soft tissue component breaking through the cortex, I mean, that's easy picking. I'm dying to go for those. You can really treat that more like a a liver biopsy than, okay. So I'll just say that, if there's any kind of cortical breakthrough, I try to go for that. But if you're talking total intrabone lesion, I kind of break them into two groups, lytic and sclerotic. Ideally, I'd want to biopsy a lytic lesion more than a sclerotic lesion, both for yield purposes, and also I think technically the lytic lesions are easier. I don't know if that's been your experience, but everything gets a little bit harder when you're talking about sclerotic bone lesions.
It is, but I find lytic to, unless it's like you said, if there's a soft tissue component and it's breaking through the bone, sometimes I'll even look at that under ultrasound, because under ultrasound, if you see that nice soft tissue component, you can biopsy it in real time and you don't even have to deal with the bone, right? Which is kind of nice.
Absolutely.
And then you maybe kind of scrape the edges of the bone for any, some extra stuff. But especially something that's down the pelvis, superficial, you don't have to mess with CT. You know, those are ideal. I agree with you. In terms of your choice of biopsy, bone biopsy lesions, a lytic lesion that has a large soft tissue component, especially around a rib, is ideal.
Yeah, absolutely.
That's when I actually pull out your just regular soft tissue side cutting biopsy needle. I don't even deal with a bone biopsy needle, right?
No. Totally agree.
It's nice.
Yep, absolutely.
Even if there's just a little, cut,
just a little bit, man. Just a little bit.
Yeah, just like barely a cortex left, you can poke through that with your barred biopsy needle. You know what I mean?
No doubt.
Which is nice.
Yes.
So I think those tend to be, like you said, easier. The one caveat I would say is sometimes they're lytic, but they're bloody. And it's kind of like what you're talking about. Oh, and by the way, audience, go and check out Chris's episode with his pathology colleague. It was
just came out
422, Pathology 101, solid advice for percutaneous biopsies. A lot of what we're talking about is you covered in great detail on that episode with great advice on collecting biopsy samples, how they process them, getting more information from the pathologist about what they're looking for. So please go check that out. But what I was saying was sometimes the lesion's bloody, right? Kind of like a thyroid, and that blood just kind of dilutes everything. You don't even know if you're getting solid tissue out because it's a blood clot. That's where it gets kind of murky. Whereas a sclerotic bone lesion, when you see that little white nugget, you're like, oh yes, I got it. You know what I mean?
Yeah, I don't disagree with that. Certainly if you're doing your biopsy with a side cutting needle or whatever needle you prefer, and you're just getting kind of what looks like fragmented, bloody, kind of like crummy little cores. I get that. Then you may have to upgrade or do something where you're more on the periphery, and then where you have to upgrade to a true bone biopsy set where you're getting a little bit of bone on the outside and then going through it. Sometimes just being on the most the most peripheral part of it is where you need to be.
Totally.
Yeah, definitely. No doubt. But that's not dissimilar than anything that you run into. That's kind of the discussion around how do you treat necrotic lesions, right?
Oh, totally. You're right.
Yeah,
exactly. A liver lesion or something like that. A lot of it's best to just have a piece of the edge of it, right?
Yep,
because you want to see that transition from normal to abnormal. I think going back to what your pathology buddy was saying was it's just nice to have that
internal
transition.
Control.
Yeah.
Yep.
Right. Okay, so that's our lytic lesions. One of my questions was what needle are you using? I think we agree. If it's a lytic lesion, you can get through the cortex. It's nice to just have an actual soft tissue biopsy lesion. Let's say it's deep in the bone, but it's a lytic lesion. The crux of it, a true bony lesion, sclerotic or lytic. I'll use a bone biopsy set, and it can vary depending on which hospital I'm at. Is just which ones I have access to, but I do like the OnControl targeted bone biopsy set. And my second choice after that is a Stryker set. Yeah.
I don't know that it has any particular name, but it's a Stryker set that also comes with, so it's a coaxial system, but one of the things that's included in it is a drill. So it's got a little drill component, and I find that drill actually gets me better cores a lot of times than the actual biopsy set.
Yeah.
So I'll get in with the coaxial system, and then I'll just drill through a lesion, and then I just pull the drill out kind of aggressively, and so it scrapes all that bone. And if anyone's ever done kyphos or anything, there's all that bone that's kind of in the thread of your drill. That's what I'm using, and I get great cores from that.
Yeah,
I really like that.
So
Stryker
that in the cup. Yeah, for sure.
Yeah, no doubt.
It pretty much is like a kyphoplasty needle. We think about
exactly.
the components of it.
Yeah.
It's just, I think it's a little bit maybe smaller. Is it 11 gauge or maybe
still 11 gauge? The one I'm using.
Yeah, still 11 gauge. Yeah, exactly. Yeah. Those are my preferences as well. The OnControl, very sharp, gets right through the bone, gets to a sclerotic lesion pretty easily. Again, referencing back to our bone marrow episode, if it's a sclerotic lesion, I might be using that drill to kind of get into the lesion, and then I'm using that inner stylet to just kind of scrape. I'm actually using usually manual force to kind of scrape as many bone fragments as I can and aspirating as I pull out. And, usually it's the first piece that you get out is nice and white or pristine. And then everything after that's pretty bloody. I don't know if that's your experience.
Yeah, similar experience. And I think that's one of the things that people run into is that's one of the things that's a little bit different from your bone biopsies is that even when you're using a coaxial system, there's just not a whole lot of play in your coaxial set. So when you take that first core, sometimes it's hard. Like you just can't, you don't have as much control over that coaxial system to bend it, to like kind of redirect it into different parts of the lesion. So oftentimes you're just like still catching the same old tract over and over. But, often in that case, like, or what I encourage people to do, or, my partners, like, I know sometimes it can be a pain, but, depending on what kind of core you get, I'll just go back in with that coaxial system just a little bit higher, a little bit lower, a little bit off to the left or a little bit off to the right, and just like restart the process again. I know it's kind of a pain, but sometimes, or at least in my experience, the bone lesions cannot be, aren't particularly high yield as like your solid organ stuff. And so I try and get as, much sample as possible.
Yeah.
Like using with the OnControl, like I still use the drill component. Like, you don't like the drill?
So I like the drill to get like into the sclerotic lesion, and then I do the inner stylet aspiration device, the actual like thing that the actual needle that captures the sample. I usually will manually twist that in, and then aspirate, because I feel like, if it's really sclerotic and I'm not getting anywhere, then I'll try the drill. But we talked about this on our bone marrow. For me, I just feel like that needle's so sharp, and with manual pressure, I can get what I need typically without having to use the drill.
Just to, so the audience knows, and maybe they haven't listened to the old one, but I'm drill like both ways. Like, so I drill into it, and then I put the drill onto the smaller needle, that like the coaxial set, to like obtain the sample.
Yeah.
Very quick, very slick.
It also,
I feel like
it depends on where it is. Like, I'm not doing that for a rib. You know what I mean? Like, I'm going to be wary. I'm going to finesse it.
Yes, you have to know what's around you, what's behind. But in general, like I feel like very in control with the drill. Like, it's just doing everything that I want it to do, and I just like have like a really tight control over it. Two hands, like one hand on the drill, another hand like kind of on the forward portion of my coaxial, and so don't have to let it go in too far, and can always make multiple passes. Yeah,
sure.
So do you prefer the OnControl? And then you like what, Stryker's like your number 2 set? What about
Stryker's
number 3?
my number 2. Yeah.
Yeah, I agree. I like the Stryker
number
set.
3. I don't usually. BD just came out with a one that I guess rivals OnControls. Like, it's got the drill and everything. Have you used it yet?
Have not used it.
To be seen. We'll see. Maybe we'll have somebody come on who knows it. I've used it once. I still prefer the OnControl, but again, I don't have. I haven't used it that many times. It's just, it was available because the OnControl was out, and that's it.
Have you used the Jamshidi set? The Jamshidi set?
Not in years. Like, I don't know the last time I would have used the Jamshidi maybe when I first came out, before OnControl was available. But usually when it was all the hospitals I worked at, usually when it was a bone lesion, they had that Stryker needle on the shelf. So I always used that. That's what I got. That's what I got really used to before the OnControl came out.
That's fortuitous for you. For years, I went with the Jamshidi system. It's just what we had. It just felt like it was ubiquitous at the places that we went. And so there's something to be said for using the device that you know really well. And so for a long time, I was just using the Jamshidi set. It's not my favorite. It kind of gets the job done, but I think there's some advantages to the OnControl and then also to the Stryker set. Most notably for the Stryker set for me, it's that inner portion that's the drill. Like, it's got the threaded component on it. Like, that makes a big difference for me. Like, I certainly don't mind like taking it with the actual coaxial introducer, but sometimes, you do it, you're in lesion, you just don't have anything that comes out. But that drill, I feel like I can always scrape some bone from somewhere. So,
yeah, I agree with you. That is a cool extra feature. I'm sure it's like an added cost for Stryker, but I agree with you. I think it's really, it's just another way to capture sample, and the drill is easy, right? You don't need the mechanical aspect to it, or the electric aspect to it. So
I'll also say, like, another tip for like when choosing your device, and I think this just goes in general, try and use the shortest needle possible. Like, you don't want, like, some of the bone lesion biopsy kits, like, I don't know, maybe it's just like what we order, but they're always trying to hand me a 15, and some of these things are kind of superficial, and having like an 11 gauge needle where you have 10 centimeters hanging out,
right,
and you can't get a whole lot of purchase, that needle's just kind of like, it's just floundering in the wind, like, and so it can make it a little bit challenging. So the appropriate needle length I find to be very helpful. That way, like, you just don't have so much hanging outside the patient's body to where, like, when you go and take that CT scan and your hand's not actually on it, it just, it'll just flop around when the patient moves, or when the CT scanner moves.
If they're a big patient and like there's just no space,
flopping in the wind.
You know? Yeah, or it's going to hit the gantry. So okay, so moving on, let's talk about anesthesia. Typically it's moderate sedation for these patients.
Yep.
Is that the case for you? Yeah.
Yep. By and large, moderate sedation.
Yeah.
Especially if we're talking like bone lesion biopsy, like it's for me, it's not all that dissimilar. Now, sometimes I have done MAC with some of them only because if it's like I don't know, someone who's a little bit squeamish, or I feel like they're gonna be prone, I may want to limit the amount of like sedation I feel comfortable giving for whatever reason, patient body habitus, bad reaction to anesthesia, whatever. I've gotten anesthesia involved sometimes to do these. And one of the reasons is if I'm using the Stryker set or sometimes the Jim Sheedy set, I'm a big fan of the mallet. Like I like the mallet in, like I don't like to muscle anything in. Like I like to always like be using like a pretty heavy mallet. I find that like when patients hear that or they feel that sensation, it's a little bit unnerving for them. And so I've used MAC, not a lot, but sometimes for bone lesion biopsies, especially if it's a sclerotic lesion. I feel like I got to tap through like a lot of like sclerotic bone to get to where I'm going.
Yeah. Yeah. Well, we'll talk about this a little bit when we get into discs, but it can change, especially because discitis can be super painful.
So I think there's some people out there who like if you can't get through, you're just muscling it and you're like twisting it. And I think that's fine. I mean, I think that gets you there a lot of the time, but try using like a really heavy mallet. And at least my experience is that with lighter taps with a big heavy mallet, you'll feel a little bit more in control, because like when you're leaning or you're putting a lot of your body weight onto like a bone lesion, or you're trying to get seated in a pedicle that may be a little sclerotic, doing a nice bone tap, like with small taps, like you can make a lot of progress. But like if you're putting all your body weight on the patient and that thing slips off, that's where you end up in places you don't intend to go.
That's
right?
true. Yeah.
And so I'm a bit advocate of using a mallet or something like that. Like I see like my partner sometimes wrapping a blue towel around their hand and just like banging on the patient. And like, I'm like, you know what? You need something with more mass. You need something like not your hand. Like in that situation, have a mallet, have it ready to go, and just have it standard for all your your bone biopsies, and like reduce that level of friction to where like you don't want to have to be waiting on it. Just have it in the room. They don't have to open it up every time. It's usually can be re-sterilized, so it's not like a disposable. Just have it in the room for bone lesion biopsies, and it'll make your life a little bit easier. That's my plug for it.
Yeah, yeah.
Everyone's been there. Everyone has used a blue towel wrapped around their hand when they don't feel like waiting for, like, where they're having trouble.
Right.
Yeah. Everyone's done it.
No, I mean, and that's how I do my kyphos. It's just the little. I think of Happy Gilmore learning how to putt. It's like tappy, tappy, tappy.
Tap it in. Tap it in.
Just like little baby steps, right? So that's how I do it too. I think that's great advice, actually. If you have them available, and you're right, it's a matter of just like having somebody grab it.
They're available.
Yeah. You just have to have somebody grab it. That's, I think, the nuisance.
Exactly.
But sometimes you don't want
to be waiting for it.
Well, you can have your CT tech just make sure they're in the room alongside the biopsy, needles.
Yeah, totally.
So, okay, so moving on, along those same lines, I want to talk a little bit about delicate or tricky spots, right? Like, for example, a sternum lesion, or maybe a lesion where you got a lot of real estate around it, like a shoulder, like a humerus lesion where you got a lot of muscle around it. What are your approaches to those tricky spots? Do you change up your anesthesia, your imaging, anything like that changes when you're dealing with a new? And you could just give, for example, like a sternum or something like that.
Yeah. So the thing about tricky spots is you try and like not put yourself in the tricky spot. So that's when like you're combing through looking for any safer area. But if you truly have to go sternum, then the next thing like you're thinking of is like, what's behind me? How can I change my trajectory to where if I miss or if I go too far in or whatever, at least I miss safely. So like I take like these weird obliquities. It's not the shortest route to get in, but it's a route that like if for some reason my needle just blew through the back end of that bone, that I'm in lung and I have a pneumo rather than my needle's not sitting in like the ascending aorta, right?
Right.
So that's just general biopsy principles. One of the things, so sternum, I can't give any great advice other than that, hopefully you don't have to biopsy the sternum. If you do, look for other spots. And then if you still do, and it has come up, like we've had like breast cancer where that's like the single isolated hot met is like coming from the sternum, and we biopsied it, but I try and like pick a trajectory That gives me a good amount of purchase. And then on the back end of that needle, like if I were to miss, and I'm not trying to miss, but if I were to miss, I'm missing safely.
Mm-hmm.
The other thing that tends to come up that I find to be like kind of a tricky location, or like when you're biopsying something in the extremity, like, humeral head, femoral head, or something that's like high up on a femur or proximal on a humerus. So patient positioning is kind of important, because what you have a big needle, and depending on the patient body habitus, if they're a really big, heavy person, that actually helps you, because like one of the things that I run into is that the biopsy needle, like as you're trying to generate some force to puncture through that cortex to get into the lesion, the arm just kind of keeps like wiggling in the wind. And so like all your force is getting absorbed by like the movement of the arm. And so I try and secure that arm really, really tight up against the body to where it reduces like the amount of wiggle room that arm is doing. And the same, I mean, you can't really do much more with a femur, but trying like choosing a trajectory to where the leg's not just kind of like flapping around on you, like going straight down on it, or putting the patient prone and being able to take a straight down approach. So I would just say, like, if you're in something that's like a proximal extremity, try and do something to secure that limb to where like all your force isn't getting absorbed by just like the movement of the extremity. Does that make sense?
Yeah, for sure. Just to go back to the sternal lesion, I didn't realize this until I was at a hospital that had these, but BD does make a dedicated sternal biopsy needle device.
I know what you're talking about.
It's very short.
Very short. It's for bone marrow biopsies, isn't it?
It's for bone marrows, but I mean, it gets you to where you need to go, and then you can always put a cutting needle through the inside of it, which I've done that before.
Yes. No. I know exactly what you're talking about. And I think it's actually a little bit smaller gauge also. I think instead of 11 gauge, it might be like 13 or something.
Yeah, but it's shorter, so it's more stable. You know what I mean? And so you don't have this big needle sticking out of their chest, which they don't like to see either, right?
Actually, so a lot of times,
you put the drape.
Yeah, so that's actually so one of the things I do for lungs or anything where something like just going straight down to the chest and the patient like can just be staring at that needle. We put a little washcloth over their eyes and we'll say, hey, it's like we're going to put you at the spa. And sometimes if they ask why, if they're like, I want to see, I just tell them, I'm like, hey, look, sometimes we administer lidocaine. That lidocaine can spray, and we're just trying to protect your eyes, which is partly true, but also it's just to get them, like, if you can remove as much like external stimuli, I find that like patients' moderate sedation goes a little bit better. Like if they can look around, see everybody, and see all the action, there's patients who will stay awake longer than they need to stay awake, or they'll kind of fight the sedation. So a little eye or a little hot washcloth over the eyes helps with sedation. It also keeps them from having to like look at this big needle that looks like it's going into their chest, which it is.
Yeah. No, that's great advice. I remember you telling me that when we were talking about anesthesia. Oh, and real quick to the audience. So the bone marrow biopsy episode was actually it's for our MSK audience, episode 39. And then for the same MSK audience, the episode that Chris did on with the pathologist was on the VI show, episode 422. So go check those out if you haven't already. All right, so I want to move on and find some time to talk about disc biopsies as well, because this is also something that comes up. Certain hospitals, it comes up, seem very often.
I know, right?
Depends on the hospital, I think, where maybe it's just patients that are maybe having, whether it be a lot of back surgery or they're just really sick and they're seeding to their disc. And commonly they're coming across, well, first of all, Chris, tell me how are they presenting? Who are they usually coming from in your practice?
Yep. So there's kind of two avenues that these patients like discitis, osteomyelitis kind of flow through us. And one is kind of like neurosurgery pain management, and that it's a patient with back pain who gets an MRI, and then the MRI read is something like, could be discitis, osteomyelitis.
Right.
And so some of those patients are outpatient that we try and get in very quickly. Not necessarily bring them through the ER, but maybe not same day, because oftentimes they're not in PO, but we'll bring them in the next day and do it. So we do have an outpatient population that just got an MRI and there's concern for discitis, osteomyelitis, and then those patients will come to us. And then there's other patients that are in-house, and these are usually a higher pre-test probability for having an active infection. And it could be prior back surgery. It could be just randomly you have a bad back infection. We have at some of our more urban hospitals like a healthy stream of IV drug abuse patients, and so oftentimes they can seed into the disc and get an infection. And actually, we handle those patient populations slightly differently. And so I know that we'll talk about it, but those are the two avenues. It's like the inpatients where they think they have an infection, and it's usually something like more concerning for infection. And then like the random MRI, like patient with back pain. And this is where I feel like your diagnostic colleagues can really box you in. Like we have some people who read it and it's always like, can't exclude like an infection. I'm like, okay, well, and like it kind of like dumps it back in the referring doctor's lap, and they're like, hey, the only way to exclude an infection, we need a disc biopsy. And you're like, okay.
Yeah.
So first, try and talk with your neuroradiology colleagues or whoever's reading the MRIs to like, if you really think it's there, no doubt you want to call it, but like not everything with degenerative disc disease is also going to be infected, right?
Right.
I get it. I read diagnostics too. I get the balance.
Yeah.
It's tough.
It is tough, and they can be just nasty looking discs that are just like
no doubt.
It's just chronic degenerative disease.
Sure.
And you don't know what's
chronic
going on.
Degenerative disease. Chronic osteo. There's a lot of things. It's a lot of like confounding pictures. No doubt. Absolutely.
Yeah. So
the struggle is real.
The struggle is real, and usually it's an MR. Maybe they previously had a CT, but usually they have an MR that just shows like inflammation enhancement, right? If it doesn't, then a lot of times we'll talk to the referring doctor, like, if there's no enhancement here, it's not, there just looks like chronic. It would look the same 2 years ago when they had an MR. Like, what are we doing here?
Sure. Right.
Because sometimes they don't look back at images. So that's the other key thing, I think, to the audience, just before you schedule a patient, look back at what they've had previously, because sometimes it's just chronic disease. You don't need to put a needle into it.
That like speaks to the workup of it. Like we still work these patients up the same way. Like we get a history, we look back for old imaging, we get labs, which include like, white count markers, CRP, ESR, all those things. But in my experience, like sometimes the picture is not exactly clear. It's a little bit muddled. I mean, every now and then you run into like some kind of smoking gun that lets you off the hook, but let's just presume that's not the case, right? Like, let's just presume like the workup is legit and like you do have to do the disc biopsy. So
yeah, for sure. So again, like, I think I know, because you've told me before, but like, what's your choice for imaging modality for these patients? I do CT, but I thought you told me that you were doing them under fluoro.
Yeah, fluoro. I love fluoro for these.
That's why I wanted to actually.
That's why I actually want to do this episode. So I used to do them under CT, and CT is fine. I mean, CT scan is the workhorse, but like what I'll say about disc biopsies is I did 0 in fellowship. I did not do a lot in residency where we did a lot of biopsies. So, I just went with what I knew, and like CT seemed to be the best choice. My partner, who does like a ton of like pain work, which include like discograms. And so like he'll do like cervical spine or lumbar spine discograms where he's got to have like a needle from like, the L1 disc all the way to L5. You don't want to do that in CT. That's a nightmare.
Right.
And so he does them under fluoro, and he taught me, and I just fell in love with like okay, that's a strong statement. I really appreciated the difference, how easy it made the procedure for me. Yeah. And so I do fluoroscopy, and we can link to this website because, picture's worth 1,000 words. That gives like the projection that I'll kind of be describing. Yeah. But if it's, with the caveat of that, sometimes CT scan is where I want to be, especially if it's like thoracic spine. Mm-hmm. But if it's lumbar spine, I think fluoroscopy for me is like the imaging modality of choice. And there are a couple of reasons. So one, I think it's faster and easier. Another thing is it is faster and easier for me to get onto a fluoro table than it is a CT table. So that's like the other caveat. Yeah.
Talk to me a little bit more about this in terms, because one of the things, it's annoying to do under CT because it's axial plane, and like you don't have time to like reformat and everything, and you're trying to avoid certain structures, exiting nerve roots and so forth. Because the thing is, we do kyphos under fluoro, and we have our target. We're targeting the pedicle, or sometimes you have to go extra pedicular in certain cases. And so I imagine it would be similar where but tell me more about your landmarks, what you're targeting, and do you have the eye angled, or are you just going straight up and down at 0 degrees?
No, you got to do a little angulation. You can use biplane. I'll typically use a single plane. And so the process is first, find the level that you want to biopsy, which to me is easier to do with fluoro than it is to CT. Like you said on CT, sometimes like the hardest part is like, you're just like, which level am I supposed to be at? Oh, yeah. Hold on. Let me also back up and say that sometimes if you're doing a spine biopsy for discitis osteomyelitis, I will go to CT. Oftentimes, like if you can get like sometimes spare paraspinal soft tissue, or even like a little, if there's like a little phlegmon or something, if you can get something out of that, that's pretty high yield. Like I don't mind going for that. But let's just say you really do want to go for the disc. Like the disc is where you think all the action is. So I bring it back to fluoro. We can just pretend it's L2, L3. I find L2, L3. I'll line up or bring those end plates into as much parallel as possible. Do you understand? Like that makes sense, right? To everybody, you think about
just like a kypho.
Yeah. Exactly, just like a kypho. So basically, like you just want to make sure that the end plates are flattened out, and that's usually requires a little bit of cranial and caudal tilt. And so I do that in like the true AP alignment. And then once I do that, I'll either use an obliquity, like where I push the eye away from me, or I bring it towards me, and it can vary. Usually I'll push it away from me, just because like it's easier for me to work that way, just like ergonomics. But you could go either way. Just that's preference. And basically, like I'm watching under fluoro, and you're trying to still create that Scotty dog effect. And so then you'll start to see your Scotty dog. And so the ear of the Scotty dog, or the superior articular process of the L3 vertebral body, will bisect that disc. So does that make sense? In that, like, you start to see the disc come into view, and the Scotty dog, that ear of the Scotty dog, will be like right in the middle of your disc.
Okay.
Like when you're looking at it.
Yeah.
And I have a link to a very nice picture that'll also like provide some pictorial assistance for this. And then so when I see that Scotty dog ear, so the superior articular process, like bisect it, that's when you know you should be seeing a lot of bone basically posterior, and then a lot of clear space anterior. And obviously you're going to biopsy the clear space. So you just find that superior articular process, just go a little bit in front of it, and then you just drive your needle down, like drill it straight down in that projection where, what's the expression? En face, or?
Yeah, en face.
When the needle's like, okay. Yeah, so you just want your needle to be en face, and like you're just driving it straight down. And at least in my experience, you'll feel a change in resistance whenever you're in disc. And so as soon as I feel like I'm pushing through like heavy sand, that's whenever I'll flip the II and I'll go into true lateral. And so in the oblique position, it looks like I'm in disc. In the oblique position, it feels like it's in disc. And then I go into the lateral position, and I see, and you in the lateral position, you can tell where you are in the anterior posterior projection, and you know that you're in disc. And then when you put in that, side cutting needle, you can look and you know exactly how far through the disc that you're going. And then sometimes even, this is just like a little bit bonus points, you can ever check yourself in the AP projection to see how far across midline you're getting, if that matters to you. But yeah, so I'll start out in that obliquity, so maybe 30, 40 degrees, and then true lateral to confirm like the AP position of that needle. Okay.
And what needle are you using again?
20 gauge side cutting needle. Like I think most of the places we go, it's like a Timno or
interesting.
A Supercore. Yeah. Timno, Supercore, or what's the one by Bard? That's really super
Bard, the Bard Mission.
Yeah, the Bard Mission. Yeah.
Ah, interesting. Okay. So I'm doing them under CT, boring old CT. This is fascinating. And maybe at the end, we can screen share that link so you can show what we can show what you're talking about. But we'll include it in the show notes anyway. But yeah, CT, just saying, prone. Also, what anesthesia are you using for
Okay,
for this?
so that goes back to our two different patient populations. A lot of times, if it's that outpatient patient who just had was getting worked up for back pain, and we just found this on an MRI, like a random MRI, and kind of have a low pretest probability, a lot of those patients are good with moderate sedation. And even kind of light, moderate to, I've done some under local. It's not a particularly painful procedure. Now, on the IV drug user side, I use MAC for almost all those patients. And that's my personal preference. One, those patients have a really low pain threshold. Two, sometimes they can be very difficult patients. And for me, it's just easier if I can tell them, look, we're going to put you completely out. I don't have to worry about them moving. Those are the patients who are the least compliant for me. And so putting them completely out makes everything quick, easy, and then it's bam, bam. I know it can be a pain working with anesthesia sometimes, but my hospitals are usually pretty good about helping me out with that. And it's a relatively short procedure. And so I prefer that for my inpatient, IV drug user patients, MAC.
Yeah. Also, I think for the same thing for the post back surgery patients, because they tend to be just in chronic bad pain.
Yeah.
And positioning and then sticking a needle in their back. They have zero tolerance for it. So I'll either have anesthesia involved and do MAC or go pretty heavy on the moderate sedation in those cases. But either way, I'm not going, because usually they're groaning even just being on the CT table.
Positioning's a big issue, no doubt.
Yeah.
Positioning's a big issue.
Okay. The other thing I want to add, I want to get into needles in a minute, but just in terms of like how you handle these samples, formalin versus wet telfa or both. How are you setting these off? Because usually it's for infection/inflammation, but like I feel like you got to send something in formalin as well, just in case, right?
I mean, the expression that I kind of go by is that, you biopsy your infections and you culture your tumors. And so, like I'm going to send something off in formalin. So I may save one, I don't know, maybe two for formalin, but the majority will put into like some kind of whatever hospital, like whatever their protocol is for just getting like a sample of something. And sometimes it's just in some sterile saline and it's in a test tube. And sometimes it's a sterile culture cup. Whatever their process is, I just go by that process. But I'm usually not putting it on a telfa pad or it's usually going in some kind of container to micro.
I should have asked you to ask that to your pathology friend, because I don't know where I got this, but it was always like a wet telfa. Like anything that's for infection, you dampen your telfa pad and throw it on there and then wrap it up and put it in a specimen cup, and that goes to micro.
I think it's perfect. Yeah. I don't see where that would be bad.
But at the same time, like, why do we even need the telfa? Like, I could just put it in the nice thing is like you can it's sterile, so you can just get everything off your needle onto the wet telfa versus trying to I guess you can just dip it in sterile saline as well. But to me, that just, I don't know. I guess that's just the way I was trained. I guess it makes sense. You could also just squirt it into some saline in a test tube. Like, why not do that?
I'm sure somebody is going to come back with a super smart answer as to why your way is completely wrong or why my way is completely wrong. But I mean, we haven't heard any complaints and we haven't got any weird bacteria growing that we thought it was like a strange contaminant because we've been doing it this way. So
I've never had anybody come back and say, why did you do that? Like, that was totally
right. Exactly. Yeah.
The other key thing is just following up and making sure like you got some result, or did you do it wrong? Because, these things are like so it's just so like, I feel like it's 50-50. Like, is there an answer here, or is it just a bunch of inflammation and that's, we didn't really accomplish anything?
Well, yeah. So I'll echo that sentiment. It's sometimes like you're not really sure what you're doing, and sometimes the cultures, like when you have like a high pretest probability, can come back negative. I will say, if we have a really high pretest probability, the cultures come back negative, I have rebiopsied. We will usually wait 3 days. Like, I want to see like 3 days of no growth before I'm going to go back. And if I do go back, I usually try and do something different. Either I want to be in a different part of the disc, or this time I decide to biopsy disc plus like the inflammatory stuff that's on the periphery of the disc. Like, the schmutz that like you can see on the CT or the MRI, I'll biopsy that. And then sometimes if on CT or even or whatever imaging modality you have, like, that there's like some in-plate erosion, then I'll try and get my needle in through that erosive part and then get some, it's probably a combination of disc bone inflammation, right? Like, I can't necessarily say that I'm in bone because it's kind of schmutz at that point, but I'll try and get more bone than I'll get disc. And so I try and do something different with my second go.
So that's why I was really interested to know like what your yield is on the side cutting biopsy needles with the disc, because to me, usually those discs, it might as well be bone. It's so inflamed and like, it's just hard and it's just not normal, right? So I got in the habit of, I got so frustrated with not really getting anything from side cutting needles that I started just using either the OnControl or Stryker needle to get right in the disc. And a lot of times what I'll do is whatever bone looks abnormal, either, the upper portion or the lower, the superior end plate or inferior end plate, I'll scrape along that and get some bone fragments as well as a chunk of the disc. And then I send that off because I just felt like I wasn't getting much with those side cutting needles. Do you ever have that issue?
I don't know. I was kind of thinking I was getting pretty good samples from the side cutting stuff.
Well, I mean, if you get them, you get them. But like, I'm not saying that. It's just like there was nothing there. It's not like I got stuff and it was negative. It was just like nothing came out. Yeah.
Yeah. If nothing came out, I would certainly do something different. Like I wouldn't just like leave it at that. But no, I feel like, I mean, and these are like 20 gauge. Sometimes I'll use an 18 gauge if I feel like it. But I mean, usually for infection, like I'm just looking for a little bit. I think you did bring up an interesting point. I mean, certainly use whatever needle like you're comfortable with and you think gives you the best results. I feel like we're doing a pretty good job with like our side cutting needles, and that may vary by like different operator, different cases a little bit. But I think one of the cruxes of the question is like sometimes these patients come back to you and they're like, you biopsy the disc. Do you always biopsy bone and disc, or do you do just disc?
I get what I can get. I mean, sometimes my angle coming in is not ideal to like get a little bit of bone. So, but I would say I aim for a little bit of bone, a little bit of disc every time.
Okay. That's fair. And I don't know if I can't say for 100% this is right. I always was under the impression that the infection started in the disc. And so my first go, if someone comes to me, I'm going to biopsy disc. And if I'm getting material out from disc, then I call it good. Now, if we do a repeat biopsy, I may change that. Or if for some reason I'm not getting great tissue from the disc. That's one of the things I also like about fluoro is I feel like I just have so much more control over that needle. Like if I want to come back in and like put it back in at a different angle, like cranial caudal wise, like where it's now like going through disc, but then it's going up into like an eroded segment of an implate, have so much control to do that. And it's like very, very facile. When CT, like it's more like, I feel like it's a little bit more of a redo, like a start over. Now sometimes you can just pull back and angle, like really torque it. But that's one of the reasons I like fluoro is like I can really see where I'm at and get I feel like I can get a little bit more granular about where my needle is.
Yeah.
And then some of these, like, I mean, like some of these like discs that you have to biopsy, like I think all of us are imagining a nice big fat disc that's infected. You know, sometimes like these discs are like totally collapsed down and like the amount of wiggle room that you have, like
it's true.
I feel like it's a nightmare to get it in the disc with CT.
Totally.
And so, that's another reason I prefer fluoro.
Yeah, you're right. And you get in there and it's just, all you feel is the crunch of bone. And so that's where I'm just kind of going up and down as I take my samples.
Yeah, right. You're just kind of walking it up and down. I get that.
Yeah. How many samples are you usually taking when you do it?
3 to 5.
Yeah.
I usually do 1 in formal and 2 in micro. And if those are good samples, then I'll call it good. But, you know, it's just not that hard to get a couple extra samples. So if it's like a little bit fragmented, then I'll grab a couple others. Or what I'll do is I'll grab 3 from kind of one location and then try and torque it in a slightly different position, either left, right, superior, inferior, and then grab it from a slightly different spot.
Yeah, exactly. If you're not getting a good sample, I mean, the nice thing is like once it's in there, it's situated. It's not going anywhere, so you don't need to re-image. You can just keep taking samples.
No.
You know,
but the nice thing with fluoro is you can re-image. It's just so easy.
You can't.
I mean, you just like tap. You just tap the pedal. Know exactly where you're at.
Yeah,
love it.
Okay, well, wrapping up here, anything to look out for post-procedure, any complications you've run across? I mean, it's bone, so like unless you're hitting surrounding structures, typically we're not causing fractures or anything like that. Anything else that you're looking for with a patient post-procedure?
If it's thoracic spine, sometimes I get a chest x-ray afterwards just to make sure that I wasn't in lung or clipped like a little piece of the lung. Now, if I'm in CT, then probably not. But if I'm in fluoro, then I'll get a chest x-ray. I'll treat it like a lung biopsy. I think there's like on CT, there's a lot of things that there's a lot of things you don't see on like CT and fluoro. Like one of the reasons I like fluoro is like I kind of have like those safe triangles from doing like transpedicular like ESIs, or not transpedicular, so transforaminal ESIs. Like I have those like safe triangles where I know where like my vascular structures are, like based off landmarks.
Yeah.
There's some vascular stuff in there. So I think it's like worth keeping them at least an hour to make sure like the anesthesia wears off. They don't have any new neurologic deficits. But by and large, I consider this like a pretty safe area to biopsy.
Yep. Okay.
And also, like I will say, like you never want to go too far anterior. That's the last place you want to be too anterior is like when you're in the spine.
Yeah, exactly. Yeah. Like that is a great point. Is just making sure whether you're doing under CT or X-ray, baby steps. I always baby step it all the way down. I know it's a little bit extra imaging, but like you said, there are things that you can hurt, especially in the spine. So, and you know, sometimes you do rub up against a nerve and they feel it right away, and then to absolutely, you know, just re-angle away from that area. So that I think is the other thing that you just learn over time, like where to stay away from, and also to like, if their pain increases suddenly, then you're in the wrong spot.
Yeah, I think with CT, it's a little bit easier to know where that neurovascular bundle is, but certainly if you're using a big gauge needle, but like with a 19 introducer, 20 gauge core, you don't want to go through nerve, certainly, and the patient will let you know usually, unless you have under MAC, like if you are going through it. But also it's like, if you're in nerve, you're probably not that far away from a vascular structure that you also want to be away from. So
right.
I think it would behoove you to take a slightly different approach.
Yeah. Okay. Well, that's all I had. Any final thoughts before we wrap up here, Chris?
No, but I do want to provide a link to that website that gives you like a nice example of like what it is to do a disc biopsy. I think just with the visualization, sometimes like the picture's worth 1,000 words. And so we can link to that. And then, ideally would love to like put a live case on, or not a live case, but like some snapshots from a live case, like showing like how to do the disc biopsy.
For those listening, Chris has a case that he's gonna go over. It's on YouTube. Something like that could go part of one of our courses as well. So
yeah.
Okay, sounds good. Thanks, everyone.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable MSK on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Jamila Kennebrew.
Thanks again, and see you next time.